The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. Welcome back to the Virtual Curbside. This is our monthly episode 4, where we get to ask our speaker all the questions that we've gotten from our episodes for the month so far. And by the way, thanks for all your questions and feedback. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Attention pediatric healthcare professionals. Are you ready to hear the latest insights on pediatric care? Sort of like you hear on the Virtual Curbside. Join us for the 47th Annual Common Problems in Pediatrics Conference happening June 3rd and 4th, 2025, all virtual. This premier event features expert speakers and cutting-edge topics, all from the comfort of your own home or office. Earn CME and MOC2, connect with colleagues, and elevate your practice. Early bird pricing ends April 4th, so don't wait. Register now at aaputah.org events. Welcome back to the Virtual Curbside. This is your host, Paul Wirkus. We're very fortunate this month. Kristi Kleinschmit said that she would come back and answer some questions. So welcome back, Kristi.
Thanks, Paul. It's great to be back.
Good. I've heard a lot of nice things about your episode, so thanks for enlightening us. Such an interesting topic. Before we start, do you want to talk about any disclosures?
I have nothing to disclose. No financial conflicts of interest. And as in all of psychiatry, occasionally we do talk about off-label medication use, but I will indicate that as it comes up.
Sure. Well, let's talk about a couple of questions. First question sounds like working on accommodations and understanding accommodations. Is there a risk that accommodations for a child, especially at school with OCD, may actually reinforce the disease? Is there a rule of thumb to help understand whether accommodations for a child with OCD are helping? How do I encourage but not enable?
Yeah, that's a great question. And so really the accommodations, especially for school, would be as you're starting to get into treatment, right? Because if, the OCD has become severe enough that their functioning has been impacted, then really we just want to get them to the best level of functioning they can get at the moment with how severe their disease is. And so if that means extra time to be able to walk through the hallways initially, just so they can practice the exposures they're supposed to be doing, then that's going to help their therapy along. But there needs to be sort of, frequent check-ins with the therapist, with the school counselor to try to figure out if the accommodations are helping them progress, and then lessening the accommodations over time to sort of encourage them to continue to work towards higher functioning.
It sounds like coordination is the key here, that accommodation doesn't mean don't go to school.
Totally. And I mean, at home too, right? So I think it's really working closely with your therapist or whoever is prescribing your medications. Hopefully you're in therapy if you have OCD, but working closely to figure out, okay, what are our exposures we're working on? What do we need the school to be doing to support that? What does home need to be doing to support that? And kind of, how are we going to move away from the accommodations to make sure, we're not enabling by keeping them on too long.
Excellent. The next question is an interesting one. Do you find that it's helpful to point out high-profile people who have talked about their OCD to help patients feel less alone? People like John Green, the novelist John Green, David Beckham, and Daniel Radcliffe, among others.
Yeah, no, that's a great question. And it's so important to give examples to people with mental illness of successful people who are doing great things in their life that also have the same disorders. I think there's a lot of stigmatization to all mental health disorders. And the more we can freely talk about the things that are impacting us, the diagnoses we have, see people successfully go through treatment, have, a really fulfilled life, the better hope I think it gives to the kids and the families that there could be a light at the end of the tunnel. And you can work through this really, really hard treatment initially and come out doing a lot better in the end.
Yeah, I know John Green's novel After the Fault in Our Stars was about OCD, Turtles All the Way Down. And I think that's a nice thing for somebody to be able to see themselves in.
Yeah, no, definitely. I would, parents can connect with other parents sometimes, like the National Alliance for the Mentally Ill, although they often will focus on adult, especially like serious and persistent mental illness. There's also, a lot of education that they have and just like groups that they'll offer for people struggling with all sorts of different mental illnesses or parenting kids with mental health disorders. And so, I think looking for online forums as well, just to get a lot of just examples of people that are going through OCD and having success with it. Or struggles, right, Paul? I mean, like, yeah, getting parents to be like, oh my gosh, I just can't, it's so hard, right? It's
Yeah.
good to commiserate.
And, especially, you look at adolescents who already feel like there must be something wrong with them. I think it's empowering to say, yeah, you're not the first person doing this. And some people have done really, really, really well.
Yeah, exactly.
All right. Okay. Ready for a swamp?
Yep, I'm ready.
Question number 4 comes in 4 parts. As you're surely aware, there's been an increase in concern about the use of SSRIs in children and adolescents. I mean, there's a lot of conversation generally these days about things like SSRIs and vaccines for that matter. We also have seen real improvement in the mental health of many children, adolescents, and young adults because of treatment with SSRIs. I'll feed you these questions in one at a time. What do we know about the safety of SSRIs in the pediatric population?
Yeah, it's a great question. And I mean, unfortunately, just like I think most of what we do in pediatric medicine, especially pediatric mental health, we just haven't had the rigorous long-term studies that, our adult counterparts have been privileged to be able to get. And so what we do know, what they have looked at, I mean, fluoxetine's been around for decades at this point. They've done some analyses of various studies compiling some of these longer term like treatment resistant depression studies to see, how are kids doing over time into adulthood. And really, we haven't seen any long term negative effects. They looked at things, even just like body mass index or height attainment or any concerns about like increased risk of diabetes, some of the stuff we worry about with the second generation antipsychotics. And they haven't been able to see any correlation of SSRI use for that. But that said, right, we don't have a ton of long-term studies of SSRIs in kids. What we do know is that, SSRI prescribing practices really for all of us would suggest just use them until remission, 6 to 12 months longer, and then try to taper kids off of them, right? I mean, we really, with especially, first onset of some of these psychiatric disorders and the first time through treatment, we're really not advocating for lifelong medication use here, right? We really want episodic treatment, get kids in therapy, and then, as soon as it makes sense to try to taper the kids back off of the medications again.
Excellent answer. Part 2. It seems that sometimes people don't like being on SSRI because they talk about emotional flattening. How do we monitor for and guard against emotional flattening?
Yeah, a couple of things. Be cautious about your starting dose to begin with, right? I mean, sometimes that's also going to lead to activation, right? So just be pragmatic, even regardless of the severity of the symptoms you're trying to treat, really, pick your like starting dose. And then if they're younger kids, half at least what the FDA starting dose would say, I think just to sort of ease them into this medication. And then really thoughtfully increase the meds. Like we certainly don't want to park somebody at too low of a dose, but we don't just want to like automatically keep increasing the dose because we think we know what the effective dose will be, and really titrate the dosing to response that you see. I also, right, will do a lot of counseling to families and to the kids that I'm seeing that, really we do want to see this normal like range of emotions, right? If we see something sad, we should feel sad. If we see something happy, we should feel happy, right? We're really trying to not bring kids to like happy all the time, but we like a good variety of emotions that they can still feel. And I really try to sort of have them anticipate that if this stops happening, right, like, please let me know, because that is something we don't want to get to, right? Like, okay, well, I can never cry, which, might feel really good if that's how you've been experiencing your depression, but a certain degree of like mood changes is normal. And that's kind of what we're targeting. So yeah, some anticipatory guidance and then slow and pragmatic med titration.
To that point, I think we often think of titration in adult terms where you sort of titrate by the size of the tablet. The next stair step is the next either half pill or full pill. And in the pediatric doses that come in a liquid formulation, they're almost infinitely titratable. That's kind of, yeah. All right, here comes another one.
Okay.
Is there a potential that SSRIs may be a short-term solution but produce long-term harm by causing changes in the way the brain produces and or processes neurotransmitters?
Yeah, and that's a good question that I certainly do not have the data to answer in a really scientific way, for lack of a better word. What we do know is the SSRIs theoretically help your brain utilize the serotonin that's there in a more effective way. And so that can help improve your anxiety and depressive symptoms. Like having depression long term can also sort of affect how your brain uses and processes neurotransmitters. And so, I think it's just always a risk benefit of it's not good for your brain to be really depressed or really anxious and be bathed in that sort of degree of impairment for a long time. And with the SSRIs, we do know that if you treat to remission, you can get kids off of the medications and they can do well, right? And so you would expect that, that would have been hopefully in studies that were sort of lacking. I think at least there should have been some trending towards much greater increase in some sort of longer term adverse outcome. But we might have to get a neuroscientist who's a psychopharmacologist on the podcast to answer that in a better way than I just did.
Well, and 2 points that you've raised along the way as well. For one thing, the things that we're treating are things that are very difficult to live with. And so it seems like that when we end up reaching for medications, we try to do it judiciously, but to alleviate something that really is a painful place to be. And the other thing is, as you've said, that this exists as part of a treatment plan, and probably makes sense to in general, pitch this as part of something that helps facilitate the other therapy they're doing.
Yeah, definitely. I think we can look back to after SSRIs started to be used, right? Our suicide rates went down in kids. And so, there's sort of population level data that would suggest that they are helpful for these, life-threatening illnesses that we see. And
that's huge. Since every suicide is a tragedy, that's
right.
huge.
Right. And then no one is ever suggesting for mild to moderate depression that, and I will counsel parents against this too. You got to get in therapy first, right? It's just, it is going to give you the most skills, right, to sort of work through difficult times in your future, help with your mood symptoms or your anxiety symptoms. And then the medications, though, we have evidence in anxiety disorders and depression that adding medicine to therapy for moderate to severe is better than just therapy or meds alone, right? So we never want to do one or the other.
Last question. This is even farther into the swamp, so feel free to do with this what you will. How do you address the questions that people raise about the effects of serotonin in the gut and on sexual development?
Yeah, I don't. I have, for lack of having a lot of rigorous questions about this, certainly there's more serotonin receptors in the gut than there is in the brain, really. And so as with we're treating illnesses that are causing dysfunction, we certainly want to be very vigilant about change in, sort of gut symptomatology, right? We don't want to be causing nausea or diarrhea or things like that. As far as, I think just sort of paying attention to just good lifestyle choices for healthy diet and healthy, just drinking water, sort of trying to keep your gut health in the best way that it can be, sort of apart from taking medications. But yeah, I don't have a great answer for that question, Paul.
Fair enough. It's the sort of thing that I think that there are more questions generally, and I think it probably behooves us to at least try to address them as honestly and respectfully as we can, as you just did.
Yeah. And I think just when I was looking in anticipation of some of these questions, just at some of the longer term data that they've tried to look at for kids, and really it was height attainment and BMI. And so, that's not necessarily sexual development per se, but at least it sort of will show us a little bit of the effective of some of those hormones.
If I'm not mistaken, for at least many of the SSRIs, sexual side effects, and I think parents sometimes don't mind treating their adolescents for that, but that sort of misses the point. And so there again, I think what we're trying to do is treat whatever we're treating for as long as it requires treatment, and then be able to taper off.
And there's ways, I mean, for the certainly sexual side effects for, our older kids that we're working with, there are other options that you can talk through with them too, if they're like sort of done with that medication and want to do something else. So.
Sure. Yeah. Well, perfect. Kristi, thank you so much for your time this month. I hope we can talk again sometime.
Yeah, no, of course. I'd love to come back.
All right. And to our listeners, thanks for listening. Make sure and like and subscribe and mention us to your friends and neighbors. And we'll talk to you next week. Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design and editing thanks to Phil Wirkus, who also composed the theme music. See you next time.